Okay, so good evening, everyone. So not to delay, I'm sorry for these few initial hiccups. So welcome to Diabetes Dilemma. And I'm very happy today that for today's session, we have two experts with me, Dr. Sujit Chandratre and Dr. Manoj Bise. So, and we all know about Diabetes Dilemma. We have this web page or a website, www.diabetesdilemma.com. And from there, you can see all the past events. You can see the upcoming programs, and one can look at the videos which have been there, scientific sessions in the past or last whatever number of years we are doing it. You can directly join also from the website or whatever the link you have received. So today we are going to have a lot of just important day-to-day practice discussion. And let me introduce first Dr. Sujit Chandratre. He is the endocrinologist from Nasik. Multiple distinctions. His actually academic career is quite, one can say that one feels envious. The gold medal from the University for MD. Also the first rank during DM. And everyone knows he's a practicing endocrinologist in Nasik and almost north of Maharashtra. Many clinical research trials. He's very much interested in the obesity and adiposity management, as he, I think, owns DEXA in his own private center. So welcome, Dr. Sujit Chandratre.
Thank you.
I also like to welcome Dr. Manoj Bise, cardiologist from Pune. He's also done DM and MD, cardiology from Grand Medical College, JJ Group of Hospitals, and basic education is from Pune. He is practicing consultant cardiologist since last 25 years in Pune and very deep knowledge and interested in, I think, in the heart failure for the diagnosis. So today we are very happy that we have Dr. Manoj Bise for the discussion in today's program. I am Dr. Shailaja Kale from Diabetes Dilemma from Pune. So we will be having some interesting discussions about fixed drug combinations and prevention of mainly the heart failure, which we call it as a preserved ejection fraction or the whole heart failure in patients with type 2 diabetes. Let me thank today's sponsors, USV, Cipla, and Servier for the today's session. So thank you so much. So I will stop sharing. I think what we are going to do today is first let Dr. Sujit start with his thoughts by sharing his slides, and then we take up the discussion. Is that correct, Sujit?
Yes, ma'am.
Okay. So I'll go on the mute now and
yeah, I'll try to share my presentation. Are the slides seen, ma'am?
no.
Okay. Some hiccups again, I believe. I think I'll have to rejoin from the link. I'll just do that, I suppose.
Otherwise, how many slides are there?
There are 38 slides, ma'am, actually.
Should we go ahead with the discussion?
Yeah, that can be done.
Is it okay?
That should be fine. Absolutely.
That should be fine. I think so.
Maybe
because
I can share now. Maybe I suppose.
Okay, just check.
Yes, yeah. Can you see it now?
त्याला विचारणं झालं का? मला नाही माहिती. मला कसं कळेल इथून? Yes, I can see now.
Yeah, perfect. Okay. Actually, it took some time in loading. So we can start with the presentation, ma'am, with your permission. It's fantastic to back again in Diabetes Dilemma with a fantastic kind of initiative by ma'am for going on for last 5 years or so now. So we have actually decided to talk about the complete metabolic care by fixed drug combination in type 2 diabetes. So this is the Christmas and Diwali time. So it's a time to gift actually. So we know that the fixed drug combination is actually a gift from India to the entire world. But of course, we have to remember that diabetes is a gift of Western lifestyle to Indians, truly speaking. So really not too much fault of us. We are accepting their lifestyle and we are getting diabetic now. We know very well the importance of glycemic control, and UKPDS long back in 1990 showed us that every 1% drop of A1C reduced the diabetic retinopathy, diabetic related deaths, myocardial infarction, macrovascular complications, amputations, and so on. And once actually we follow up the data in 21, we had the follow-up data. We know that those people who went into the intensive, so-called intensive therapy that time with only metformin, just to keep HbA1c at around 8, had a lot of improvement in the all-cause mortality and myocardial infarction also. We remember that in UKPDS, the myocardial infarction was not statistically significant. Actually, it was 16% reduction, but it did not meet the statistical significance. But now we know that intensity of lifestyle and treatment we have, that is always beneficial. Those patients who were not treated with intensive lifestyle within first year versus those who were treated with intensive treatment after first year had a lot of difference, and the AMI increased by 67%, the stroke by 51%, heart failure by 64%, and composite CV events by 62%. So that was the only difference of initiation of intensive therapy in diabetic. The therapy intensity was similar, but only the timing was different. We had the typical sequential treatment approach in the beginning, and WHO and ADA had actually recommended that. So initially it was thought that the addition of second drug came after 2.5 years or so. The third drug came after 7 years or so, and adding insulin was after beyond 7 years. Most of the times the intensification was quite delayed. With the advent of GPP, DPP4 inhibitors and SGLT2 inhibitors, usually they are added 4 years later, really speaking. So now the ADA has completely taken a U-turn. In 2024 guidelines, it is said that early combination therapy can be considered in adult with type 2 diabetes. Of course, we have been doing that for the last 20 years, giving combination therapies quite early in India. But of course, now the entire world is actually waking up to it. Verify study was something which was eye-opener, that only metformin may not be enough for type 2 diabetes, the simplest type. And most of the endos in the world actually are not treating diabetes with only metformin anywhere. Usually they go on a combination after Verify. And we know that the combination therapy, the duration and the secondary failure is much, much better as compared to only metformin with compared to vildagliptin with metformin. We typically have seen the ominous octet of defronzo hundreds of the times, and multiple mechanisms can be tackled by multiple medications. So DPP4 inhibitors can act on the glucagon, on the lipolysis, on the incretin effect. Metformin can act on the liver and on the muscle uptake. SGLT2 on the kidneys and the pancreas, of course. And everything combined can control a lot of metabolic dysregulation in type 2 diabetes. So what is a fixed drug combination? It's actually 2 or more drugs. They can be combined in a single dosage to contribute the claimed effect. And the dosage of each component is such that the combination is safe and effective for a significant patient population. It can't be catering to a tiny percentage of patient population. It should be most of the patient population apart from the special cases. The rationale would be, it should be based on certain aspects, like the drug in combination should act in different mechanisms. The pharmacokinetics should match. They should not vary very differently. And that's how actually the sustained release metformin was really invented for a fixed drug combination. And it should not have a supra-additive toxicity of any of the ingredients. That's absolutely essential thing. We know by multiple studies that the fixed drug combination would improve the adherence quite to a great extent, because number of pills have a psychological impact on patient's mindset, and lesser are the pills, better is the kind of adherence. Now we had a double combination in the beginning, and now there are of course indications for triple combination. The AAC guidelines came way back in 2014, really speaking, talked about entry level of HbA1c where we could combine 3 drugs in the beginning itself. Now the recent guidelines, of course, the WHO and AAC and AD and AAC guidelines are showing that whenever there is entry level A1c is very high and there are certain conditions, we can directly go on 3 drug combination, and that is again a rational thing. There are multiple case scenarios. We talk about lot about DPP4 inhibitor, SGLT2 inhibitors, and metformin combination, but there are a lot of case scenarios where we can go on sulfonylurea-based triple combination therapy. So of course, this is a case representative. We won't go in detail because of lack of time. But when somebody is on glimepiride and metformin combination and somebody is not well controlled, then of course we can add a third drug in form of DPP4 inhibitor or SGLT2 inhibitor, or even a voglibose basically to this combination. where these combinations are readily available in the market. Again, we can have a sitagliptin with metformin combination, and the sugars are not really well controlled. So we can add maybe a sulfonylurea SGLT2 inhibitor or anything per se. Again, there is a rationale for triple combination when, of course, two drugs are going on and it doesn't control the sugars that well. And similar cases in that scenarios. So what is the advantage of the fixed drug combination? There is a lesser pill burden, which is quite obvious. This lesser cost than individual medications in most of the cases. The adherence is much better. It does reduce the clinical inertia on the term of clinician to add multiple agents. And there are certain combinations which neutralize adverse effects of each other, like DPP4 inhibitors with SGLT2 inhibitors. And of course, there could be additional pathophysiological benefits. There could be disadvantages also. Timing in relation to the food can be actually troublesome. Metformin better is to be given after the food, where glimepiride can be given before the food. So we actually are confused when the combination comes up. There could be confusing names actually. There could be suddenly like Trijardi is a name of one of the combination. Nobody can make out what the actually real combination would be. The dose titration of individual components is almost impossible. And of course, when there is a complication like say renal impairment or a cardiac problem, the use could become actually limited because we might like to increase certain drug and decrease certain drug. So what are the possible combinations for optimal glycemic control? Metformin along with either DPP4 inhibitor, SGLT2 inhibitor, pioglitazone, sulfonylureas, alpha glucoside inhibitor would be a good combination. Triple drugs actually in the first three drugs would be to reduce the risk of hypoglycemia, where the third drug along with metformin could be DPP4 and SGLT2 inhibitor or pioglitazone. And if at all we need a very high potency, we can use a sulfonylurea along with metformin, with the third drug being varied, really speaking. So in short, when we consider FDC, for SU metformin, it's for mainly for glycemic control. DPP for metformin, basically for low risk of hypoglycemia. SGLT2I with DPP4 inhibitor would be low risk of hypo with weight neutrality and maybe no GI issues. Triple combination of SGLT2 inhibitor, DPP4, metformin would be a powerful glycemic control with low risk of hypoglycemia. Whenever we add a SU, it would be basically for a powerful glycemic control. So in general, we can get adherence, reduce pill burden, and reduce cost with this. If at all we talk about the most famous combination of SGLT2 inhibitor with DPP4 inhibitors, it can act on multiple pathophysiological points also. And if at all we add a metformin to that as a third combination, of course, there are multiple trials now, multiple combinations available, which is depicted here. We also have the Empalina FDC. It is actually kind of a lottery. This is one of the safest combination on multiple parameters. We have seen that right now, this is the easiest combination to give for most of the patients, including the all spectra of renal EGFR with the cardiac kind of conditions. Saxa-DAPA FDC actually has got another kind of characteristic that DAPA increases glucagon, and that would be reduced by saxagliptin. DPP4 inhibitors may actually reduce the risk of urinary tract infections associated with SGLT2 inhibitors. So that is another advantage of such combinations. As I said, Saxa and DAPA has actually got a unique kind of property where the DAPA goes up with DAPA use actually causes increased glucagon values, which saxagliptin actually can control the same value in speaking. So there are possible effects of combinations on the cardiometabolic risk factors. Of course, metformin being the prime content of all the FDCs. So we do have aspects like weight loss, BP reduction, CV and renal benefits, low risk of hypoglycemia, and powerful early efficacy with these kind of combinations, if at all we don't take out the SUs in that. We have to remember one thing, that the naming is very confusing sometimes. We have Istamate G2, which is a Sun Pharma medicine, which is a triple combination along with the sitagliptin, metformin, glimepiride, and there is one Instamate by Gainer Biotech by metformin and glimepiride only. So the drug should be clearly written. It should be quite decipherable. We should not get any confusion in the dispensing. It should be dispensed only by prescription, because there is a high degree of mistakes that can actually happen. Pharmacovigilance would be very important. It would be challenging because there are multiple drugs and there is unknown effect of combination therapy. Patient education is absolutely important. The tablet size should not go up because of multiple agents in the same thing. And of course, there is lack of long-term studies using the real FDCs, truly speaking, right now. When there is reduced EGFR, we have to think of the FDCs. Some of them go out actually of the window. That's why we have to remember that we can actually think of individual agents, how they are indicated in multiple situations. So in conclusion, we would just wind up. FDCs are welcome additions to the current treatment strategies. They help to improve the clinical inertia and therapeutic adherence. There is need to improve education of prescribers, pharmacists, and patients to avoid mistakes, and improve drug labeling and prescription practices would help really speak. So thanks a lot. With this, I'll stop sharing the screen right now, and I'll hand the greens back to Shailaja Kale. Ma'am, you're muted.
So perfect. So this is the background set up by Dr. Sujit Chandratre. And that's right. That's what we are going to discuss. And the 2 points which he said is you cannot treat type 2 diabetes with one single drug. You need multiple drugs because of the philosophy of treating type 2 diabetes, because of multiple pathophysiologic mechanisms. So we always use 2, 3, 4 drugs, and FDC becomes that all drugs in one pill. So that is one thing. So the most important benefit, what I feel, is adherence, which he has rightly said. Lot of meta-analysis have shown the number of pills go down, adherence improves. The simpler prescriptions, adherence improves. Simple insulin regimen, adherence improves. So I think the foremost important is adherence, which he said. Then less hypoglycemia, because you can reduce the doses of all sulfonylureas there. And now we have Indian companies have like 0.5, 30 milligram of glycoside, 0.5 milligrams of glimepiride in FDCs, which give us a lot of flexibility, which was not earlier. But with now different combinations, we can avoid hypoglycemia. But there are lots of other advantages, which he has already said, but we'll discuss in a short time. So first, let me just have this thing. The standard way of classifying type 2 diabetes complications was like microvascular and macrovascular. That's what it was taught to us, like retinopathy, nephropathy, neuropathy, and macrovascular, cardiovascular, peripheral vascular, and stroke, cerebrovascular. But we know it's not true. It's diabetic nephropathy is no more a microvascular complications. It's a diabetic kidney disease. So there's so many things happen in that. The adiposity, obesity, weight, inflammation, duration of diabetes, they play so much of role in diabetic kidney disease. It doesn't remain a simple microvascular complication. Simple neuropathy also, the nerve disease in diabetes, has lot of other dimensions. So newly diagnosed 10-20% of patients can have neuropathy because of, again, obesity and lipotoxicity with that adiposity, which is creating lot of problems in the blood vessels along with hyperglycemia. And then if you just restrict micro and macro, you forget about talking about liver, you forget about cancer. The leading cause of death in type 2 diabetes is not heart disease, because I think cardiologists are doing a great job. The leading cause of death is cancer. So you forget cancer, you forget liver disease, you forget sarcopenia, you forget diabetic brain disease or cognitive dysfunction. So a routine screening of type 2 diabetes, which we do in our clinic, we just do neuropathy screening, retinopathy, cardiovascular test. It's not enough. Do we do cancer prevention, routine screening of each and every patient? Rarely. We know it, but it's not that, because we are not taught, we don't discuss. Liver, now it has started a lot. So that's what we need, this complete metabolic control, because when you come again and again for cancer, adiposity, obesity is important along with diabetes, which pushes for chronic liver disease like NASH. Again, you need this adiposity, obesity management. So here also comes the role of FDC, right, Sujit? So
Yes.
Especially now we'll come to a complication called as heart failure. And heart failure is nothing to do with cardiovascular risk. Though it's a part of heart, but we should not club it with cardiovascular risk. Heart failure can be called as a microvascular complication. And it is definitely related to the adiposity and the obesity. Younger age of onset. More the young the patient, like especially in India, early they get diagnosis, they have kind of a more chance of getting this heart failure of type 2 diabetes. The individual cardiomyocyte is affected. Individual microcirculation, which actually gives blood flow to the myocardium, gets affected, which we used to call in type 1 diabetic, myocardiopathy. Similar kind of thing is happening. There are lots of papers which talk about pericardial fat and epicardial fat, which has a strong correlation with the heart failure. So it's not at all only the cardiovascular risk but the large arteries. So let's come to discuss about, we are still discussing FDCs and we are also going to discuss about heart failure together, because I think it's like everything treats the FDC I mainly use to prevent heart failure in my patient. That dose of SGLT2 inhibitor in a FDC in a patient who get diabetes like at the age of 35 definitely will prevent heart failure. So FDC is also addressing the complications like kidney disease, heart failure, chronic liver disease. So FDCs are very important. So as we are discussing heart failure, Dr. Bise, like still standard heart failure in every physician's mind is like low ejection fraction. Patient comes with breathlessness, edema, and first thing you give Lasix and oxygen. So like that was the like initial heart failure. Still it is the strong concept. We talk a lot about preserved ejection fraction or whatever, normal ejection fraction heart failure. So can you just elaborate types of heart failure which we discuss in type 2 diabetes?
So basically,
I think Manoj, you have two things have joined. So there is an echo.
Should I leave and come back?
You can, there are two instruments have joined.
Yeah.
So you leave from one of them.
I don't know. Leave meeting.
Yeah, I think you're fine. And now just unmute yourself. Can you unmute? You are muted. Or you can leave and rejoin, I think.
Okay. Now, am I audible now?
Perfect. Yes.
Okay. So, heart failure has seen a lot of changes in the last 10 years. And basically, with the introduction of newer drugs, as diabetes has seen. And I still believe that heart failure diagnosis, we are not doing enough. Okay. The pro-BNP usage is very, very minuscule. And even if the other factors are indicating uh, breathlessness and structural heart disease in echo, even a mildly raised pro-BNP, because in all these trials, they have just taken the thing above 250 and above 350 as the pro-BNP levels, and probably the pathological reports would tell us that it should be taken as a positive only above 500 or 750, specifically in elderly people. So there is a lot of need for clinical correlation when we need to diagnose specifically HFpEF. So previously it was a depressed LV systolic function which was less than 30%. Then it was a moderate LV systolic function which was 30 to 45%. And from 45 to 55, we used to call it mildly compromised. And these were the echo findings or the echo ejection fraction. Okay. When all these trials with Paradigm HF, which I think happened in 2014, that is nearly 10 years back, they changed the thing to a new classification, and that is the HFrEF, that is the heart failure with reduced. And this time it is not depressed, it is reduced. So it's just a play of words, but they included all the patients lesser than 40%. So less than 40% is HFrEF now. And probably we used to call this as moderate LV systolic function 10 years back. But now this is so. And then from 40 to 50, we call it as mid-range or mildly reduced or whatever, mid-range EF. And the third is the HFpEF. And there was no possible treatment available for HFpEF unless the patient had pulmonary congestion. So when the patient had pulmonary congestion, as you said, that we gave IV Lasix, we put a BiPAP, and say, started an NTG drip, and when he improved, he used to feel better in a day or two, and then we used to say it's all fine. And specifically in renally impaired patients, we used to always call volume overload. So volume overload मध्ये गेला, bus. That was the thing which we used, and we never correlated it that this could also be a diastolic heart failure or a HFpEF. Now, with all these newer things, and specifically SGL2, which has been given a class 1 indication in almost all kinds of heart failure and in HFpEF, the need has arisen that we have to diagnose somehow the HFpEF. So for HFpEF, one is a structural heart. So either he has some amount of elevated systolic dysfunction or left ventricular hypertrophy or LA dilatation or some mild PH. So some abnormality has to be there in the echo. And the other is assessment of the diastolic function, which has changed in 2016, because when all this discussion came up, we probably realized that we are way back, and we are just saying type 1, type 2, type 3, and we are just giving a grade to the severity of diastolic dysfunction. We are not telling about the filling pressures. And filling pressures is the thing that would tell us that this patient needs long term treatment, because again, the filling pressures would become high if we stop the treatment. So here in 2016, they changed the entire thing, and there was a, I think, cardiologist in Cleveland or something called Nage, Sheriff Nage, and he was the main lead who devised this. And then he said that you have to grade the severity of diastolic dysfunction as 1, 2, 3. One is benign, and he brought a lot of changes in what should be said as type 1. So initially we used to, diagnose it just by the pattern that the E wave is less, the E wave is smaller than the A wave, and that is it. Now he says that the E wave velocity should be less than 50 centimeters, and the ratio should be less than 0.8, not 1. So many of those patients whom we thought it's just a type 1 would be a type 2, and 50% of patients with type 2 pseudonormal diastolic dysfunction would have high filling pressures. And there is a Nages formula to calculate the PCWP, because the PCWP would be the same as the LA mean pressure, would be the same as the left ventricular end diastolic pressure or the pulmonary venous pressure. Because if that becomes high, he will intermittently go in pulmonary congestion and have breathlessness. So the calculation is by a tissue Doppler, that is E dash, the E wave velocity with the mitral flow. So you take that ratio, you add 3. So we could calculate the PCWP in this. Now, do all regular routine patients need a calculation of E by E dash or PCWP? No. So it has to be selective. So the question arises that would we do echo in such details to get abnormalities? And then he has suggested also that mild pulmonary hypertension plus LA dilatation will tell you that this is more likely to have high filling pressures. So we cardiologists are coronary centric. Even in diabetes, we try to just dig out ischemic heart disease, coronary artery disease. I agree that this is important, and if there is a significant, coronary stenosis, it has to be tackled. Revascularization has to be done. But apart from that, we have to look at the other things to say that this patient is going to go into heart failure in future or not. So the first thing is symptoms, and even the symptom, elicitation is very, very poor, even by cardiologists, because breathlessness is not a very easy clinical symptom to evaluate. The second is structural heart disease. The third is diastolic function assessment, and fourth is pro-BNP-NT. Now, all four things together, we have to, make a clinical judgment as to what we believe in HFpEF. And should we give this diagnosis in our echo reports? No. Still, Heart failure is still a clinical diagnosis. It's a clinical syndrome. So from the report, the treating doctor has to make this inference that this is probably HFpEF.
So what I gather, so important. I know Dr. Manoj Bise to everyone. He is very much involved when it comes to heart structure and giving his opinions. So, Dr. Manoj, suppose there is a typical tendency in everyone who treats patients, all of us, fatty liver, okay, that's normal. Type 1 diastolic dysfunction, okay, you ignore it, it's normal. So now it has changed. So suppose the echo report says type 2 diastolic dysfunction. What should we do? Should we ask a cardiologist to look
Yeah,
into it and
to-
give us filling
to give
pressures
us
and a
the
detailed
PCWP,
report?
to give you the
And if the
PCWP.
symptoms are there, we should do NT-proBNP.
Yeah, and give you the PCWP, it will help you.
Okay.
So the concept is now coming on. And since I said that not many people are very keen to spend time on an ultrasound machine, specifically cardiologists, they would prefer to spend their time in the cath lab instead. So, but if you spend some time, so the question is who is to do it? So, uh, very few ultrasounds are done by technicians. I don't know. I think Dr. Kai will know this.
Almost all.
Yeah.
By technicians?
No, ultrasound abdomen,
Oh,
80%,
no,
90%
that is by
by
radiologist.
radiologists.
That is by
Okay.
radiologist. Yes.
So suppose I say 80%, it is the opposite when the echo is concerned.
Yes.
So even we have to train those technicians to give these values, because they would do it, and then that report is important for a diabetologist, for an endocrinologist, for a nephrologist, for everybody. So we have to train them for this, and some effort is going to be needed to say, because right now there is some treatment available.
Yeah,
So
that's
we
why.
have to go.
Because
That's
the
why
treatment is available, we are discussing this.
now many cardiologists do say that, suppose I have this patient whom I feel is severe hypertension, moderate LVH, he has diabetes and he has HFpEF. Okay, when I start SGL2, and suppose diabetic or non-diabetic, it does not matter, but suppose SGL2 is on board, there is no symptomatic relief to the patient. Okay, symptomatic relief to the patient is only by diuretics or a small dose of beta blockers, because it will reduce the congestion. So we have to understand that SGL2 is going to work slow. It is going to prevent the long term hospitalization. It is going to benefit the metabolism of the heart in the long term. So the results would be seen in the long term. Lasix and diuretics are just short term treatment options. And with that, obviously, we have to ask them to reduce the obesity,
Yeah.
increase their exercise capacity and everything.
So, and also some patients, when I heard this paradigm trial, where it was even in preserved ejection fraction, in women especially, the ARNI was doing good. So, if NT-proBNP is high and preserved ejection fraction, patients, SGLT2 inhibitors we don't need because we give it to everyone, because they are good even as a oral hypoglycemic
Yeah,
agents.
we
If I
are.
want to upscale, like using diuretic, using ARNI in these patients or preserved ejection fraction heart failure, because every woman of 50, 60 with diabetes, obesity has breathlessness on exertion. So it's like, it's difficult clinically, but then we need to dig into the detail of echo and talk to you and then get a proper diagnosis.
Yeah,
Or
but
are there any other tests other than 2D echo? NT-proBNP we discussed. Is there a third test to diagnose this?
there is a diastolic stress test in which we do the assessment of the diastolic function at rest, make the patient exercise, and see his diastolic parameters. If they deteriorate, it means that the diastolic function is playing truant when he's exercising. So there is a to dig out. This is done very, very rarely, but this is available. And then there is a routine, the ECG and the treadmill and CT coronary angio. Actually, I was just because the stress test is a very weak test for diagnosis of ischemic heart disease. The sensitivity specificity is, at best 60%, 60-65%. And if you're standing next to the patient when he's doing a stress test, physician is standing, probably his judgment that this is truly positive would be much more, but nobody stands, so the technicians are doing it. So, the PH center has been taken over by Vijay, and I was talking to the CEO there, and he says that the CT coronary angio, which is actually a fantastic test in, up to age 65, maybe, because the calcification of the coronary is not much till 60-65. So if there is any, discussion on whether the stress test is plus minus, okay, they do nearly 3 or 4 times as much as CT coronary angio in Andhra Pradesh or Hyderabad as compared to Pune. And he was
It's very less.
surprised.
Pune, it is very less.
Just very less. So there are many who would, say ki we don't want to go for an invasive test. In that, I think now many centers have a very, very powerful CT scan machine, whatever slice, 56, 64, 126, I think 284 is also there. So it can be done very, very fast, in really 10 minutes after ivabradine and beta blockers, once the heart rate is down. And the negative predictive value of CT coronary angio is very good. So, that part can be sorted out, that the CAD is not there, and then you can focus on the heart failure management. In time to come, what we foresee is that the EF is not going to matter. Okay, because the Paragon trial in ARNI, in the subgroup analysis, why did the Paragon fail? Because we have used it in HFpEF, the ARNI, and anecdotally it is very, very useful. Patients relief is
Yeah.
fantastic. And so
Patients
everywhere
improve.
it is not so.
Clinically, patients improve.
Patient really improved. So they did the sub analysis of the Paragon HF, and they found that a ejection fraction lesser than 57%. I don't know from where they got such an odd number, 57%. And females do
Yeah.
respond very well to ARNI. So 55 means you're almost at most of the range of the EF in heart failure. And females, okay, we can give them, one brownie point, but you could use now SGL2, you could use ARNI in HFpEF because of Paragon, and a few trials are ongoing. You could use the MRAs as a diuretic. You're allowed. Why not? It will also be beneficial as a diuretic. And beta blockers, if
Yeah.
it's even hypertensive or sympathetic overdrive, it will take care. So probably we are looking that this distinction will go away. Heart failure means 4 pillars. Period.
Okay. Just like our FDCs,
It will make it easy.
give it to them. We can have a
Give it
FDC
to
of
them.
all the
Yes,
things
and it will
together.
make it easy, because I don't think so. Not many people are going to. All the cardiologists are looking at ways and means where you can do away with the echo findings.
Okay. Yeah.
Okay.
So,
In the Emperor Reduce, they use the E by E dash ratio. They used it. They used also the LA volume. They used the pH. But still, cardiologists believe that HFpEF is a clinical diagnosis plus pro-BNP-NT, period.
but there are a lot of reports which say LA dilatation is seen.
But that is significant.
That is significant. These
That
patients
is
needs to be.
significant. It
Yes.
needs to be attended to.
Yes. So, Sujit, looking at this discussion as we see are talking about early, patient may not have symptoms. Echo may come just as normal as we discussed. So, how your SGLT2 inhibitor in a fixed drug combination is helping our patients to improve? Can you just have your thoughts on this, or what is the mechanism?
Basically, when the drug came long back, most of us were the principal investigators in the CANA and Smith, and I was there. Initially, the drug had no glamour, really speaking. As Sir said in 2014, suddenly it turned out that it was good for heart and later on for the kidney. So all the big guns like cardios and nephros entered the market, I suppose, and we are basically now just writing the medicine. And of course, it's more written by the cardiologist. We know from the beginning that it could be pumps versus pipes. Initially, we did not know whether it would help the coronary artery disease or only the heart failure part of it. Now we know that it's not only the metabolic, but also remodeling part of the cardiac muscle and the cardiac endothelium. So SGLT2 inhibitors would have multiple mechanisms. It's first of all free calorie clearance, really speaking, from the body. The sugars are thrown out. So the basic mechanism why heart failure happens in diabetes would be initially before any structural change because of insulin resistance. The cardiomyocytes are deprived of glucose from the circulation. They have to do with the free fatty acid metabolism with lot of accumulation of toxic end products in them. And that's how the structural changes do start. That's from the beginning itself. Most of the diabetics are actually obese. So there is a lot of obesity, as we know, is an endocrine disorder, and the adipose tissue is an endocrine organ with a lot of cytokines getting secreted. They're quite harmful for the heart. Many diabetics do have renal dysfunction. So these actually cytokines are retained in the circulation. So all these are actually taken care by SGLT2 inhibitors. The glucose uptake does go up. Of course, the glucotoxicity is improved. And as we said that we know that DAPA or even all the DAPA and EMPA do work well in non-diabetic population also. They do have something without really speaking glycemic metabolism, something to do with the cardiomyocytes. All the mechanisms are not very clear, but what is clear is randomized control trials and the results are clearly in front of us. They are wonder drugs right now, and they are going to stay here at least for 10 years for the want of maybe better medications. So multiple mechanisms, right from cellular, metabolic, to availability of the glucose, to the structural changes, they do help. And also they improve the coronary artery blood flow, which will also be the contributor to the development of heart failure in the long run.
Yeah, so there was a lot of papers I heard last year about redistribution of fat, which happens also with SGLT2 inhibitors. And of course, GLP-1 analogs, as you said, pumps and pipes. And now we have some report about GLP-1 analogs are also used for heart failure, even preserved ejection fraction. Still, they're not strong recommendation 1A evidence, but it is showing the SOUL trial results. So even that, this redistribution of fat, SGLT2 inhibitors, yes, easily available. They are there in fixed drug combination. GLP-1 analogs are coming. We are getting biosimilar GLP-1 analogs. Even oral sema is coming, which will be cheaper. And even what I want to say is lifestyle changes. Like a simple weight loss, will it help to prevent heart failure?
Definitely.
Yes, both.
Basically, lifestyle, of course, we always knew it is a wonderful drug, and that's the first prescription actually in every doctor's recommendation to diabetes or even without diabetes for anything. We know that now it's not only diabetes or RDC, CKM and CKML nowadays. And what it has done is it has put obesity as grade 1 CKM, really speaking. So obesity used to be always pre-diabetic, pre-hypertensive, a lifestyle condition, but now it is come under the scenario of or under the spectrum of a disease per se. Lifestyle is absolutely essential. Maintenance of weight. The early report started from Dean Ornish's trials in 1995 and all, which actually showed some reversal of coronary artery disease with primitive techniques, but however, it was shown like that. Dr. Neil Bernard studies for diabetes remission. And of course, now Dr. Roy Taylor's. The follow-up of those patients is absolutely amazing. Those who can stick to 10% weight loss can do wonders in the later lives. And most of the chronic disorders and the mortalities go down with the lifestyle modification. So the crux of the thing is fat loss. Of course, not actually the weight loss, the fat loss per se, that to central fat loss, not the muscle mass or the bone loss, which happens in certain patients with erratic kind of weight loss efforts. So the fat loss would be absolutely essential. Overall, 10 to 15% of weight loss in an overweight person would do wonders, really speaking.
Your comment, Dr. Manoj?
No, it is essential.
It's essential.
It is
Yes.
very essential. No
I
question.
would like to add that we always say there are different, I don't want to go into different cluster definitions, but we do have, as an Indian type 2 diabetic, when we have this thin and very severe hyperglycemia, insulin deficient. But we do have these obese patients or overweight central adiposity who are more insulin resistant as well as insulin deficient. This group of patients, which was more predominant as seen in Dr. Mohan's paper, as well as when these patients were correlated with genetic studies published from Dr. Yajnik's group, they are more prone for diabetic kidney disease and heart problems. So we are really treating a very high risk population of type 2 diabetes, where one needs to be aware of these issues for heart and the kidney, and we need to use all the drugs which are available along with lifestyle modification, which is crucial. Now, just because we are on a weight loss, I'm just asking a question to Dr. Sujit. Whether you lose weight by a lifestyle intervention, whether it is on like GLP-1 analogs, when you regain the weight, when you stop the treatment or the lifestyle intervention, which is very aggressive, is stopped, patients regain weight. Everyone regains weight. And then this weight regain is morely fat. And also this weight loss, which you see with SGLT2 inhibitors. So I have two questions. One is how to deal with this regain weight, which is more fat. And the second question, do we lose muscle mass with SGLT2 inhibitors?
The multiple studies with Mounjaro, with semaglutide, in both the forms, Ozempic and the Rybelsus, has shown that what your weight is lost, around 25% would be lean body mass, not necessarily muscle always. It could be some protein which would be part of the degenerated cells and maybe the waste material. It could be part of bone or blood also, or the blood cells also. But we do lose 25% of the protein mass totally, and 75% to be the tune of obesity. Of course, one good thing is that the visceral fat would be lost to greater extent than the peripheral fat. That is one good welcome thing. But there is nonetheless protein loss definitely seen in all those kinds of weight losses. Not only with that, even intensive exercise regimens, we do see some muscle loss. There is no question about it. Whenever we gain it back, we gain fat. So whatever we do, it has to be taken for the entire life. Somebody goes and joins gym for 3 months, that is absolutely not advisable. It has to put a membership for 5 years and maybe decide to do, maybe go slow, but start with the low dose, go slow, but don't lose that kind of a track. Now, SGLT2 inhibitors, we can continue for a longer time. GLP-1 receptor agonist, semaglutide, it's very difficult to continue with this kind of a cost. Some or the other day, patients are going to go off it, and there's going to be a big population of patients who have gained fat back again. We don't have a huge data as yet because of lack of numbers, but we do expect a lot of epidemic of regaining or rebound kind of weight gain and fat gain people. So those patients who really want to go off the GLP-1 receptor agonists have to be absolutely on intensive lifestyle regimen. With the lesser weight, a lower amount of food intake is going to sustain that kind of weight because the metabolism goes down to the tune of 10 to 20% in people who lose the weight. That's the natural mechanism of body, that how we cope with the famines actually in jungle conditions when we used to live in evolution. So that we have to understand the journey is going to be tough. The patient has to be braced from the beginning. He puts good efforts and continues with the same. Actually, we can overcome this problem. Otherwise, it's going to be a universal problem later.
So I think what we should be insisting on muscle strengthening exercises.
Absolutely.
To all our patients, and not only for this fat loss or muscle gain, but even as a routine exercise thing, which does wonders for blood pressure. So yes, in a fixed drug combination, though I'm using a SGLT2 inhibitor or I'm giving a lifestyle modification, but muscle strengthening exercises is a must as a prescription to all our patients, which may reduce this risk. Another question I have this, because we are talking about fixed drug combinations, what can we offer our patients to tackling their chronic liver disease? Chronic liver disease or MAS-LD or the NASH. So do we have some drugs which can prevent this other than lifestyle?
Yeah, Dr. Bisay or me, madam?
Sujit, yeah.
Absolutely. So, of course, the weight loss would be the biggest drug, we would say. So whatever causes weight loss actually does help. We know that very, very well. So SGLT2 inhibitors help, metformin does help. Even mobilibos has shown in certain studies. There are new drugs coming up. GLP-1 receptor agonists are a great help, really speaking, to reduce the FibroScan scores in the fatty liver. But of course, we have now certain drugs which are actually recommended. Those are not available yet in India, but that would be the future. Finally, the prevention would be the biggest kind of the cure, I would say. And it's important not to gain fat in the beginning itself. So all these drugs for weight loss, SGLT2 inhibitors to some extent, though pioglitazone causes weight gain to some extent, it does help on the liver fat. And of course, SGLT2 inhibitors along with the metformin. Those are the drugs right now commonly used. The drugs which are the Rimotone, which is actually approved by FDA, is not really available here. I have not seen a single patient being on that regimen. So we don't have any first-hand experience of the drug which is approved right now. Saroglitazole, of course, we have a biopsy-proven data, Indian company, though not featuring on the global platforms as yet, does work well in the some small subset of 30 patients of biopsy before and after cohort actually. So even that could be thought of as a maybe Indian local drug for the Indian NASH patients.
Yeah, so when we say complete metabolic control with fixed drug combination, this aspect is also important. It's not only early heart failure, but when you see this MSLD or NASH and grade 2, 3 liver fat or fibroscans are showing towards kind of a beginning, I think we should, even empagliflozin has trials which are biopsy proven trials, which show the reversal of fibrosis. So these drugs are also helping in actually preventing chronic liver disease. And of course, we have saroglitazone and pioglitazone, which also we can use along with, of course, weight loss thing. So we are just coming to the end of today. So Dr. Manoj Bhise, I will like to ask you again that you told us about, can you just summarize the tests which we should do 1, 2, 3, 4 for all our patients if I want to really diagnose the heart failure, which is not below 40%.
Which
So
is not
2D echo.
2D echo with diastolic indices. So you
Correct.
can always mention, and probably then they would do it. So 2D echo with diastolic indices, a chest X-ray, and pro-BNP-NT. I think this should be sufficient.
Yes,
A good clinical history.
exactly. Yes. So I think any last message, Dr. Sujit, you want to give so that we can just stop today's.
Yeah, basically, we have to start early and suspect everything in the diabetes per se. Diabetic comes with a whole lot of complications. We tend to involve the cardiologist and the nephrologist quite late in the time per se. So we have to suspect as soon as the patient enters our clinic. It's already 10 years late. That's what we have to think and hit from all the aspects so that we can prolong the lives of our patient. And second, the whole community level work should be done on the prevention of diabetes. I believe that there would be only two kind of populations tomorrow in the world, diabetic and non-diabetic. That's going to happen maybe 50% of each. So it's going to be rapidly progressing epidemic we have. So we have to really put a lot of efforts in the prevention of diabetes for the future generation. That's what we say.
Just we have answered whatever few questions were there. Everything was taken. Just one question, which is query about the use of pioglitazone. Because one way we are saying it prevents chronic liver disease, and other way we know it in what heart conditions. So like every heart, where should not use pioglitazone? Sujit, yeah.
Okay, so of course, any NYHA maybe grade 2, 3, we would not use it, but otherwise we can use it. Maybe even FPF, we don't know whether it's helpful or not. The data is quite sparse as yet. We just know about ARNIs and SGLT2 inhibitors. Maybe it would be useful. We need long-term data, of course. Pioglitazone has gone out of the pharma favor now, so I don't think there would be a lot of long-term trials on pioglitazone right now. But it's still a good drug. As all the diabetologists, we know that it's used to be a very nice drug actually. Somehow with the rosiglitazone fiasco, it has gone a disrepute. So we can actually look forward for some data from here and there, or maybe some subsets of population, we can get some data about it.
So, okay. So thank you so much. And we do use small dose pioglitazone in a lot of patients for multiple things. So coming to the end, I will just like to summarize that fixed drug combinations are going to stay. Just a simple, just in clinical practice, we don't start on the first day with a newly diagnosed patient on a FDC. We take 2-3 weeks to titrate different our oral hypoglycemic agents, to decide the dose, to have some concept about side effects, and then we transfer within few weeks to our FDC, which again improves adherence. So FDCs are a great welcome with so many combinations available in Indian market. So it becomes more kind of flexible for us. I'm sure very soon FDC will come for the 4 pillars of heart failure as well from India. I'm sure there will be an SGLT2 inhibitor and ERNI and everything together. So it's not very far away. And one needs to, as Dr. Bhise initially said, we are not that kind of looking into the diastolic heart failure the way we should be. So let's ask our cardiologist colleagues to dig into the details of 2D echo about their diastolic functioning. Let's start doing NT-proBNP more and use these SGLT2 inhibitors we are using, but also ERNI in some cases where we can definitely treat this kind of a preserved ejection fraction heart failure. So thank you so much. I think it was a good thought to screen our patients more for heart failure side, use lifestyle intervention very aggressively in our day-to-day practice. Thank you so much.
Good night. Thank
Good
you.
night. Thank you. Bye. I thank once again our today's sponsors, USV, Servier, and Cipla. Thank you so much.
Thank you.